actually introduce our first keynote speaker, who is charged with helping to set that tone. Patrick Corrigan is the professor of psychiatry at Northwestern University and executive director of the Center for Psychiatric Rehabilitation at Evanston, Northwestern Healthcare. The center's services, research, and training program dedicated to the needs of people with psychiatric disability and their families. Patrick has been a principal investigator of federally funded studies on rehab, team leadership, and consumer-operated services, and on stigma grants. 4 years ago, he became the PI, as we call it, the principal investigator of the Chicago Consortium for Stigma Research. And this is, for those of you who are interested in such things, the only NIMH-funded research center examining the stigma of mental illness. You'll hear more of these from additional speakers, but he certainly qualifies. Dr. Corrigan's a prolific researcher, and he's published more than 10 books and more than 200 papers. He's got multiple awards, and I was especially intrigued, just to mention two of them, that he received the Most Innovative Mental Health Program Award from the Alliance for the Mentally Ill in Illinois in '96, and he received the Dr. Martin Luther King Jr. Humanitarian Award for University of Chicago Hospitals in 2000. He, at this point in time, is one of the true leaders in thinking about stigma and in actually recommending next steps. So please join me in welcoming Dr. Patrick Corrigan.
Thank you. Thanks for inviting me to this conference. I had the fortune to come to the first annual conference on depression, which is very impressive. But what's really here is you can see the group's getting bigger and bigger as time goes on. I wanted to focus on the issue of stigma. You know, mental illness strikes with a two-edged sword. On one side is the impact of the symptoms, the disabilities, the distress of mental illness, in this case of depression, but it equally applies to schizophrenia, bipolar disorder, anxiety disorder. On the other side is the stigma, is the impact of a public saying that you're less than everybody else because you have mental illness. Stigma, which drives people away from treatment, so not likely to benefit from what's going on nowadays. And stigma, beating oneself over the head with it because they see themselves as a person with mental illness. What I want to do with you for the next hour is talk to you about the findings of our research. As Dr. Graydon said, I'm head of the Chicago Consortium for Stigma Research, which is a collection of 9 academic units and about 25 different faculty, and share with you what we found during that time. The other thing I want to focus on is my own personal experiences. You talk a lot about the way to handle serious mental illness for people that come out. So I'm a person with a serious neuropsychiatric disorder. Amongst other things, what's hounded me the last 6 months is the side effects from the neuropsychiatric disorder. And I alert this to you because if you see some of the side effects like shaky hands or tremulous voice or momentarily get lost, because you're the choir I'm preaching to, it gives some meaning to what's going on. And so similarly, people with mental illness might want to learn how to frame their illnesses and their side effects so that people who are from the choir, again, people who are empathic with that issue can know how to respond. Let me start with a quote. This is from Booker T. Washington. He's meaningful and important for several reasons. As you know, he was known as a free man during the Civil War era. It's a black man who earned his own freedom. And he said, in all things that are purely social, we can be as separate as the fingers, yet one as a hand, and all things essential to mutual progress. And I put this up front for a couple reasons. Perhaps the biggest reason is to remind me that the issue of the stigma of mental illness is not a health care issue per se. The stigma of mental illness is an issue of social justice. It's an issue of people not being given the opportunities they deserve by virtue of living in our country. Let me give you an example of stigma. Here's Franklin Goodman. This is sort of a prototype of people I've worked with over my life. Franklin Goodman was fully employed in a hardware store, lived in his own apartment, had hobbies. This is Chicago, so we play that softball. It's about the size of a beach ball. Had a concerned mother, hospitalized many times. When I saw him for the first time, it was an acute flare-up. It was an inpatient coming in the emergency room, was quite distressed by what was going on, was quite shaky by it, actually hit a attendant while he was there. He clearly needed some time to recover because, as we found out later, he's suffering from schizophrenia. Compare that to Harriet Oglesby. Harriet is fully employed as a clerk typist, lived in her own apartment, had her own hobbies, had a concerned parent. Harriet, too, was hospitalized many times. When I saw her, she was hospitalized for acute flare-up because she came in a diabetic coma. Clearly, they both had pretty serious mental illnesses. What's the course of it? Well, Harriet, after a short convalescence, went back to work. She went back to her apartment. She had to learn how to manage her sugar levels better. But after getting some training from the nurse, she was able to do that, go back to her hobbies, pretty much continue the social life she had to begin with. Compare that to Franklin. Franklin lost his job, lost his apartment, because his parents were concerned that this is just going to keep going on because, after all, schizophrenia leads to an irrevocable downhill course. He had to give up his hobby, he had to move across town, and lost his friends. Now, an important thing about stigma, I nor nobody else in the team could blame the parents. By that I mean they had the best intentions for their son, but they also bought into the stigma and had a bad outcome. What's the difference between these two folks? They both had serious mental illnesses. They both had serious illnesses. They both had to live with convalescence for a while. They both are likely to have recurrence. The difference is in the kind of illnesses they had. So in our work in stigma and mental illness, what we work on is what we seem to know, and the best place to get information about what we seem to know about breaking stigma is from advocates, because they're living with this issue day in and day out and ways to try to overcome stigma. What we need to know, which is what I as a researcher are trying to partner with advocates so we can come up with better information about how to beat stigma, and how do we change it. And that's the most important thing. Because, as an academic, we all can sit around with the academic sort of approaches but not really hit on this idea of how you're going to beat it. And I think it's important because, like many epistemologists, I realize that knowledge is power. That the more knowledge I have about this that I can share with advocates and other groups, the more power they'll have in trying to overcome it. If you're interested in our work, this is our website. Again, this is the collaboration that we have in Chicago, www.stigmaresearch.org. We're also available to be partners on research. It's what our mission is. Feel free to give us an email. Where does stigma come from? Well, a good place to start is where stigma generally comes from in the world, where the stereotypes and prejudice generally impact us. Sam Keen wrote a book called Faces of the Enemy, and in this book he argued that one of the ways in which the majority has kept the minority down is through images of groups that were disrespectful and dehumanizing. We see this, for example, in issues of race. As a white man, I still cringe every time I show this because the white race had a long history of disrespecting people of color. The interesting thing about this one is not only how disrespectful it is, but also how it came from a science textbook. So it's a science textbook out of the 1890s, which is something to keep in the back of your mind, is sometimes people use science to disrespect and keep a group down. This is an interesting image. This is from World War II. This is a Jew represented as a rat. Again, it's interesting to keep that in mind because sometimes people disrespect groups by introducing them as rats. What that does, it justifies me viewing them as different than the majority and therefore justifies me somehow impacting and discriminating against them. You see it for what one half of the population has done with the other half of the population over the last umpteen years. In this place, women's proper place. It's interesting, though, in putting these three down and talking about African Americans, Jews, and women, in some ways, the disrespect, the prejudice against them has gone away. Now, don't get me wrong. It's still there, but it's gone undercover. So while there might have been a time in America to disrespect people of color, that's gone undercover somewhat. The point is that much of what I'm going to show you now is really quite common and frequent in terms of people with mental illness. The stigma of mental illness, one of the big places it comes from is movies. The most popular cinematic maniac since Darth Vader. Jason, right? In Friday the 13th. I'm an expert in this because I have a 16-year-old son. One of the interesting things is, you always think that your son will follow in your footsteps. I was in Washington giving a speech while my son and my family were in California at Disneyland. And when we actually came back at O'Hare at the same time. And when he got off the airplane, he had this hat on that said "Psycho" in red letters and red splotches over it. I was going to take a picture of him to show as an example of stigma, but this is not a real poster. It's a collage that an advocate put together, but it sort of hits what the key points are in terms of this homicidal maniac. It keeps the idea of schizo as somehow people have a split personality. It has this lascivious aspect to it of an attractive woman. It has this frightful person from behind, and this paranoid aspect that people are going to chase after you. And when we tie that to issues of schizo or schizophrenia, we clearly have this idea that the stigma of mental illness is getting worse. Okay, how much worse? I mean, is it really getting worse, or are we just all sort of preaching to a group and it's really not so bad out there? Bruce Link and Joe Phelan, who are two esteemed researchers from Columbia, did a study, collected data in 1996 on dangerousness of light, and they just happened to have the same measures collected in 1956, both probability samples, which gave you a 40-year window to see how stigma changed. You would hope that there's more knowledge about stigma out there right now. What they found is actually stigma of mental illness has gotten worse. That viewing people with mental illness as aggressive is a lot worse. Now, we're post-hocking the data, but the best guess of why that is because of television. Because what's the image of people with mental illness on television? The image is that they're dangerous or frightening or scary. You see this image of people as homicidal maniacs in the newspapers. Freed mental patient kills mom, from the New York Post. Oops. Now, this is the New York Post, and they're supposed to write stuff like this, right? That's how they get our attention. And this is actually about 15 years ago now, but we really don't have this kind of image anymore. Well, Trenton State Hospital in New Jersey about a year and a half ago had a fire at the hospital. And the Trenton newspaper the next day wrote as a banner headline, "Roasted Nuts." So still this kind of image. But again, these are sort of like the prostitutes of advertising. Compare that to this. Is this man a monster? For those of you who don't know, Reader is like the Village Voice, except it's in Chicago, the Village Voice being in New York. This is a very esteemed publication, comes out once a week, tends to write towards people's intellect, tends to motivate people. In this story, though, they were wondering whether the gentleman on the left was ready to get out of the state hospital because he had unfortunately killed his wife about 15 years later. Now, all the psychiatrists involved in the case and all the court were ready to have this person be sent to a halfway house, but the newspaper sort of worsened the task by jumping in with this kind of message. United Schizophrenics of America. This is from New Yorker magazine, perpetuating this sort of split personality idea. People with mental illness are homicidal maniacs. You see it in advertising. Now, the problem with advertising is so omnipresent. This offer gets you committed. To offer these deals, we'd have to be committed. Maniac out of control. Again, we're bombarded with these images of people with mental illness being dangerous and somehow needing to be locked up. Lobster lunacy. This was actually on a billboard I drove by to work every day. And anybody figure out what this is? Yeah, it's a straitjacket filled with nuts, which won the National Advertising Award several years back. One person, a person of color, told me that selling this is like similar to trying to sell rope by showing a lynching. I mean, for people who've been in straitjackets, it's probably one of the more frightening things that's happened to them. And this, to make it out, you can't quite see it, there's a pair of legs hanging down and a chair kicked over and the note contemplating suicide. The idea being that this is a printing shop and they're saying if you're contemplating suicide, would you let them know so they can help with your invitations. Now, the interesting thing about this is only about a year old. The interesting thing about this is they actually called the proprietor of the store trying to point out to them why this is disruptive and the proprietor of the store is a lady in the middle, and she just sort of threw her hands up and said, what's the big deal? So even when you bring up the issue, people don't get it. That's disrespectful towards people with mental illness. You see it in comics. You don't suppose this guy really is FBI, do you? Or this, just plain nuts. Now, I have to make tell you that I'm a big fan of Gary Larson. And I've always liked his kind of approach to things. The problem with this, though, is it says not only using a disrespectful image like nuts, but it's saying that we, the mental health professionals, are in disrespecting these guys. We're in on the gag. You can laugh with us about them. See it in kids' books and TVs? S is also for Stanley. Stanley's a crazy murderer who likes to murder little boys and girls early Sunday morning. Are you afraid of Stanley? Interesting thing is this is Shel Silverstein's book. Shel Silverstein, as many of you parents know, is a very popular, very well done books on all sorts of issues. This is from his dictionary. To his credit, if I could say there is a credit, this was in the 1960s, so it was in a even less enlightened time than we have now. Animaniacs, remember the rat as a Jew. Here we got some strange characters as maniacal. The one big stigma we talked about is the dangerous stigma. The idea you should be afraid of people with mental illness because they're dangerous. They might snap at any time. They're unpredictable. The other stigma to talk about is benevolent stigma. It's a strange choice of words. By benevolent stigma, it's that the population tends to view people with mental illness as childlike or unable to make decisions for themselves. So just like my daughter has me to make decisions, so I should similarly make decisions for adults in areas they're incapable of acting because of these kind of simpletons. You see it in this one, The Dream Team, with Peter Boyle, Michael Keaton, and Christopher Lloyd. This is a story about 4 psychiatric patients who got away from their van by accident and had a zany, weird, silly day in Manhattan. You see it in this one now. It's about 3 or 4 years old now. It's Jim Carrey's Me, Myself, and Irene. Again, perpetuating the idea that people with mental illness are split personalities, and even making it worse. One split is dangerous, and the other split is sort of a simpleton. You see this in this cartoon where Crazy Glue comes from? And in this, How to Avoid Hiring Lemons, Nuts, and Flakes, the most interesting thing about this poster is an HR department did it. Their goal is to show how to manage difficult fellow staff members. Otto Wall wrote a book called Media Madness, which is an excellent book which recaps many of these kind of images I've shown you. You can usually get it either from the NAMI website or from Amazon. Bob Lundy and I wrote a book called Don't Call Me Nuts. The purpose of that book was to pick up where Otto left off. What we wanted to focus on is not just whether it's a problem, because again, I have folks like you around who can tell me, yes, this is a big problem, but how to fix it, how to overcome the problem. So that's what I want to focus on today. But first, a definition of terms. This will allow me to be academic at the University of Michigan. Attitudes are statements of apparent fact that have an emotional response. So the desserts are sweet and provide a wonderful end to a day. Desserts are sweet, the apparent fact, have a wonderful end of the day. Desserts make me fat, I hate them. Stereotypes are these kind of statements about people. All Irish Americans are artistic souls. This is the one stereotype that's actually true. All Irishmen are drunken sots. Well, luckily you weren't around St. Patrick's Day. These are examples, both positive and negative, of stereotypes. Prejudice is agreeing with the stereotype and having an emotional reaction as a result. That's right, all Irish American are artists, I love them. Or that's right, all Irish Americans are drunk, I hate them. Discrimination is a reaction you have because of that hatred. Therefore, I'm not going to hire them, I'm not going to rent to them, I'm not going to let them go out with my daughter. All the different results of buying into that prejudice. Now, the interesting thing about stereotypes is you really can't, as a result of living in a Western culture, or any culture for that matter, you pick up certain stereotypes just as a result of living there. Many of us know stereotypes about people of color, about women, about Irishmen and the like. The difference between stereotypes and prejudice is a choice to agree with the stereotype and act on it. So again, we all get to adulthood, we know a lot of these stereotypes, it does not mean we necessarily buy into it. What are the stereotypes about mental illness? Well, the one I told you earlier is dangerousness. It's a big concern that people with mental illness are viewed as homicidal, unpredictable, and the like. The next one is a weak character. It's a belief that they're to blame for their mental illness. that they're unable to take care of themselves, they're unable to do what they're supposed to do, and therefore they have a weak character. Incompetence, the idea they're not able to take care of themselves or anything they're responsible for. And benevolence, the view that people with mental illness are cute and somehow need to be taken care of for or succored in some way. The prejudice, and the two big emotions that result from prejudice is fear, which results from the dangerousness issue, and anger, which results from the blame issue. Is I'm mad at you because you're not taking care of yourself, you're not doing what you need to be doing. Discrimination breaks out 4 different ways in terms of public discrimination. First, in terms of withholding help, is you're not taking care of yourself, so I'm not for giving you help, and I'm not for the legislator giving you more money either. Avoidance is you're dangerous as mentally ill, and therefore I want to stay away from you, and I want you to work where I work or live where I live. Coercion, which is you aren't capable of making decisions for yourself, so somebody else needs to make these decisions for yourself, be they doctors, nurses, and the like. And segregation is the best place for you to be taken care of as institutions that are away from me. And so in recent research we've done, there's still an appreciable number of people that will buy into any or all of these discriminations. An interesting additional thing about the stigma of mental illness, stigma of any sort, is whether it's obvious or manifest. For example, in looking in this room with some level of reliability, I can identify who's a person of color, who's a person, who's a woman, as opposed to what gender, physical disability, who's in a wheelchair, whether people are overweight, whether they're homeless, disheveled, whether they're very short for height, or poverty also being disheveled. There's some stigmas you just can't hide. So again, women, for the most part, it's impossible to hide the fact that they're a woman. People of color, it's very difficult to hide the fact they're of color. There are other stigmas, however, that are pretty well hidden. Sexual orientation is one. Is unless you told me who was gay and who was straight, I wouldn't be able to guess from looking around the room. Or religious background, Jew versus Muslim versus Christian. Criminal past, education, all things that are hidden. Mental illness, for the most part, is not hidden. Now, sometimes people say, oh, I can tell what people are crazy all the time. Well, much of our times in social interactions, we're doing about business, and we don't necessarily dovetail into delusions or other kinds of difficult behavior. And for the same point, substance abuse is mostly hidden. So you can't tell whether or not a person has a substance abuse problem. The interesting thing about it being hidden is one of the big decisions that people with mental illness have to make is whether or not they should come out. Whether or not they should come out in part to change society, because as society sees more and more people coming out, they're going to realize that mental illness is not a rare event, it's quite a common event, and people with mental illness are really not grossly different than I am. The other thing about coming out is that coming out has a big impact on the person themselves. I've benefited a lot from looking at the gay literature. In the gay literature, they say that most people, when they come out gay, tend to feel much better about themselves. They tend to have a better sense of self-esteem. They've been in the closet all this time. They didn't do anything wrong. And so similar, what we're looking for is in a project we're just starting up, is whether or not people with mental illness report a similar kind of response. Let me talk a little bit about models of mental illness, how we understand mental illness as an event, and then talk about how we try to change it. And the big model we work on is we segregated, we split up public stereotype and self-stereotype. As I said earlier, the cognitive structures of stigma can be broken up into stereotypes, prejudice, or discrimination. Stereotypes are negative beliefs about a group, and these include dangerousness, incompetence, and character weakness. So when the public views a person with mental illness, because that person came out, or that person's publicly labeled because they were seen coming out of a psychiatrist's office. The public might view them as dangerous, incompetence, or character weakness. They might agree with that view and have an negative emotional response as a result, anger or fear. And they might discriminate against them, avoid them for work and housing options and the like. What happens to a person with mental illness who's brought up in this same society and they find themselves in that group of mentally ill? In terms of stereotypes, they have negative beliefs about themselves, which leads to character weakness and incompetence. In terms of prejudice, they agree with that and turn it in against themselves. So they have low self-esteem and low self-efficacy. You know what low self-efficacy is? is there's a why try effect. Why should I try getting a job? I'm a mentally ill person and incapable of it. Why should I try to live on my own? I'm a mentally ill person and incapable of it. And so it leads to self-discrimination in terms of failing to pursue work and housing opportunities. The theory we're most interested in for understanding stigma is Attribution Theory by Bernard Weiner. In borrowing this theory, what we've come up with are path models that have held up to our research to look at two different ways understanding a person with mental illness leads to discrimination. The first one is if you believe a person with mental illness is responsible or to blame for their mental illness, you're likely to be angry with them, you're less likely to pity them, and they're both likely to lead to less help. So the idea is if you have some sense of responsibility about a person with mental illness, it can lead to less help. The problem is that while Weiner's attribution theory leads to some useful predictions, it doesn't hit what tends to be the major stigma of mental illness, namely danger. So by dangers, if you view a person with mental illness as dangerous, you tend to fear them and you tend to avoid them. So these are two models we've used that help us understand why people respond in a discriminatory way. They also help to generate an attribution question that we use for our research that I'll show you in a minute. How are we going to change stigma? That's really what I talk about the most. Some years ago, I wrote a paper with David Penn where we divided all the different ways of understanding stigma into three possible areas. Education, trying to change the myths of mental illness with the facts. Protest, trying to suppress or challenge statements about mental illness. And contact, actually facilitating interactions between people with mental illness and the public. Education. One of the myths about mental illness is people with serious mental illness are dangerous. First, the fact, because this is debated a lot in the literature, in part because advocates would like to say that people with mental illness are no more dangerous than the rest of the population. That's unfortunately untrue. That epidemiologic research suggests that people with mental illness are on the order of 3 or 4 times more dangerous than the comparison group. But the problem with that fact can be shown in terms of what's the best predictor in this crowd for me to identify somebody who's likely to be dangerous. If I went around and had your mental health history, how good would that be? Actually, the single best predictor of who's dangerous with mental illness is gender, is men. Men are on the order of about 10 times more dangerous than women are. Is age, young men are on the order of about 15 times more dangerous and depressed. And black young men are on the order of 20 times more depressed. Now, if I were to propose a good treatment program in a prophylactic sense of somehow intervening in all young black males, hopefully everybody in the room would be appalled by that. And yet sometimes that's what we're doing with mental illness when we argue that there's evidence that people with mental illness are more dangerous. Protest. The idea, again, about protest is to review stigmatizing images and try to suppress those kind of images. The problem with protest, I would say protest is my prototype of the hellfire preacher who's saying, stop that, the worst thing's going to come to you, stop thinking that way. The problem with that is protest tends to lead to a rebound effect. Let me show you a rebound effect. For the next 5 minutes, I do not want you to think about white bears. Hopefully most of you have little polar bears jumping around your head right now. I used to like to say, don't think about Gilligan Island's theme song, but days later people would come back wondering how to shake that down. The interesting thing is when you ask people not to think bad things about a group, then they tend to rebound and actually thoughts about it tend to be a little bit worse. One reason is because to not think about something is an active process. You got to keep it out, keep it out, keep it out. Another one is a reactance effect of don't tell me what to think kind of approach. To me, what's one of the more interesting studies they did on this is they took about 100 undergrad men and put them in one room, split them in 2 rooms, hooked them up to plethysmographs, which are the instruments to tell whether the person is sexually aroused. And in this room didn't say anything, and this room says do not think about sexually arousing behavior. And needless to say, so rebound is a potent response, making us somewhat hesitant to recommend protest as a way of changing attitudes. Let me be clear, I think protest is a very good way of changing behavior. I mean, the anecdotal sort of effects of that are consumer groups who go out to theaters when they're playing Psycho 3 or the like. Or, anybody remember the show Wonderland? Wonderland was on TV about 3 years ago in the summer. Actually, I think it was in the spring. In the first episode of Wonderland, a person with mental illness shot 5 policemen and stabbed a pregnant woman in the belly with a hypodermic needle. So clearly they were going to perpetuate this idea of dangerousness and unpredictability and out of control. The long and the short is, over several weeks of going back and forth, the NAMI and Mental Health Association got the Stigma group, got the group to drop its show with 5 unshown episodes. So by 5 unshown episodes, if those are $1 million apiece, they would rather throw $5 million in the can than risk the anger of organized consumer groups. The third way of changing stigma is contact. When I've done this research, I've actually done it with my co-author, Bob Lundeen. He is a person with schizoaffective disorder. And the way it works is we can do it several different ways. One way is in a setting where he'll talk to a group like a Rotary about his experiences with mental illness. In fact, the story he tells is that his name is Bob, and he has a severe mental illness. My childhood was not unusual. That's an important thing to say, because one of the stigma that comes out is that if you're mentally ill as an adult, you were probably born weird as a child. And so what he wants to say is there's nothing wrong with the parents. There's nothing wrong with childhood. This is something that came out as a young adult. In his case, it came out when he was about 25. Also, unfortunately, his mental illness did not go away quickly. By that, the idea is this is not test anxiety. This is a pretty significant kind of event that's going on for him. Despite these problems, he's achieved several accomplishments. He now lives on his own. He works full-time at a university. He's got a whole kindred group of friends and family members. They won strange things. He recently one day went out and bought a silver Volkswagen Beetle, but we can excuse those kind of things. So he ends with 2 take-home messages. The first one is that I, like the vast majority of people with mental illness, are like you. One of the pernicious, insidious aspects to stigma is the idea of separating one group from the rest of the population. Whenever somebody's viewed as different, it justifies us in treating them in a less respectful way. And so he secondly ends with, so please treat me the same. Do not view me or my life in terms of any unfair stereotypes. One of the interesting things we've done in this kind of research is what we call a for real effect. Bob will go to a group of 60 employers. He'll tell his story. He gets all done. They go, for real? I mean, like, are you really mentally ill? It's interesting, in terms of telling one's life story, mental illness seems to have a different credence to it than gays and lesbians. I mean, when I think of a gay or lesbian coming out, they come out and everybody in the audience says, okay, you're gay or lesbian, and then they proceed to apply whatever stigma they have as a result. When a mentally ill person comes out, they have to qualify. I mean, are you really mentally ill? Do you have symptoms? Do you have meds? Have you been hospitalized? Seems to be the big kicker. So that kind of stuff leads to leads to some sort of genuineness in one's reaction to it. We've done some work about stigma. What I wanted to do is make sure we had enough time for questions, so I just wanted to focus on one of the studies. And what we found in earlier research is that education seems to have some positive impact on attitudes about mental illness. Contact, on the other hand, works best. Before we did this study, what we didn't have is any kind of information about whether improving stigma sticks over time, whether it maintains over time, does it affect behavior, and how does content matter and what you're teaching and what you're talking about. So we did a study, and we randomized people to 5 groups. So one of the groups were randomized to control condition. In all our research, you have to have control conditions because there's a social desirability effect. Is when you're in a study listening to people talk to you about mental illness pre-test and post-test, you're likely to figure out, well, they want to know if I'm prejudiced about mental illness or not, and they're going to go down a bit. So you always need to look at whether or not stigma is decreased or not. We randomly assigned them to 2 contact conditions. The first contact condition looked at responsibility. So the person who did that contact condition, a consumer, talked about whether he was to blame for his mental illness. The second one talked about dangerousness, whether or not he talked about his life experience, whether he's dangerous or other people he knows mentally ill are dangerous. The other 2 got referred to education conditions. Education for dangerousness was the same thing, but instead of having a person with mental illness do it, some sort of teacher-like figure did it. Similarly, education about responsibility was looking at the issue of blame or not. So we had 5 different groups, and what we're really interested in is whether contact was better or worse than education. To put in perspective, this is a measure looking at dangerousness pre and post. All the rest of these are all set up on the x-axis in the same way. This is a control condition. This is education about danger, education about responsibility, contact about dangers, and contact about responsibility. And what you find is for the this is the pre versus post effect. So the pink are the pre scores, and the brown are the post scores. What you find is a small improvement in control condition, because again, the social desirability effect will impact on people. What's most interesting, though, is in terms of dangerousness, you'll see a progressive step function. So as things became more consistent with contact in terms of danger, responsibility, the stigma decreased going down the line. So you see pre-test actually a little bit higher here. But in terms of pre-test for avoidance, you see that people actually were more likely to endorse avoidance after the test. People in the education danger condition were a little less likely to avoid. And you go right on down the line. So people in the contact condition showed huge impact in terms of being less likely to avoid people with mental illness. The interesting thing about this is the follow-up measure. And while these all went to baseline, the 2 contact conditions continue to be much lower. You see it in social distance measures. By social distance measures, I mean I don't want people to work around me, I don't want them to babysit my kids and the like. Again, if you look at the brown, you see a step down, so that there's clearly a great improvement in contact and for dangerousness and responsibility. Some improvement for education and responsibility. And again, we're looking at pre-post findings. In terms of pre-post, again, the education went back almost to baseline, whereas there still showed some effect here. One of the things we're always interested in is trying to come up with a behavioral measure. Because a lot of times you use attitude measures, you ask people what they think about in terms of their group. And of course, most people figure out what kind of question you're looking for. And so we were interested in some kind of measure to be a proxy of behavior. So for participating in the study, we gave all participants $20, $10. We gave all participants $10 for participating in the study and told them it's theirs to keep, or they can decide to turn around and refund any or all that money back for the National Alliance of Mentally Ill. And what this is a measure of how much money people gave back. How much money they gave back. So as you can see, as you move up towards contact, they're giving a lot more money back than towards this other directions. What we know from this study, contact clearly seems to work better than education in this kind of setting. It seems to have some influence on behavior, though we need to broaden the behavioral measure in future research. The effect seems to remain over time, but there seem to be some moderating or mediating factors that might account for these results too. One of the moderating or mediating factors is the level of disconfirmation in the contact. In other words, do you meet somebody who's exactly like your stereotype, who's a lot better or a lot worse than your stereotype? Grossly disconfirming the stereotype is what we would call high. This tends to be famous people. So Dr. Corrigan gave examples of Mike Wallace. Other people like that have those illnesses come out. Would they have a better effect or a less effect? The low would be meaning to people who are acutely ill and disabled. So you met a person who's homeless, living on the streets. That's likely to reinforce your stigma. Medium is meaning our neighbors and coworkers who live next to us. Now the interesting thing is we did this study and found, in this case, the higher the score, the more likely that people are to diminish stigma. This is the low group, which actually means a person with mental illness, as you can see, who's acutely ill, is actually going to is actually going to reinforce your stereotype. Moderate leads to a big finding, and high leads to a less so finding. This is not statistically significant, but it's close. But it sort of mirrors what people say about using famous people like John Nash and Patty Duke and Margot Kidder, using famous people like that as a way to decrease stigma, is it might be an example of what's called the Thurgood Marshall effect. Thurgood Marshall, as you know, was the first African-American Supreme Court judge. And when he was appointed in the 60s, progressive people thought, well, maybe white people who aren't open-minded will see Thurgood Marshall as a very accomplished person, and therefore their attitudes about blacks will change. But what they found is that attitudes about Thurgood Marshall changed, but it doesn't tend to generalize to the rest of the population. So perhaps using famous people like Mike Wallace might change effects. Perhaps the best, though, is when neighbors, people next door, come out with their mental illness. Research also shows that one-time contact with people with mental illness has an impressive effect. So meeting Bob for one time in a group tends to lead to decreased stigma. However, repeated contact leads to supreme effect that it tends to maintain over time. One of the ways to accomplish repeated contact is to get people to come out of the closet. Because it's concealable stigma, you cannot tell, as similar to gay people or people of certain religious groups, you can't tell who's got it and who doesn't. Now, if you look at mental illness being somewhere around, by the time you add in all different mental illnesses, somewhere around 25% of the population, plus all the families involved, if that group ever came out in any sizable amount, it would easily overcome other groups that have a good constituency. Some of the issues about coming out, as I said before, one of the big issues is that people who come out, it generates huge sense of relief and self-esteem. There also is more support among peers. I mean, again, if you work for a company of 1,000 people, statistically, there's going to be quite a few of those people who are mentally ill. Now, they're not coming out and you're not coming out, but once somebody does admit, then you get a sort of a cluster of people who are all struggling with the same kind of symptoms and disabilities, and that kind of support on the job can promote better work. There are costs, though, to coming out. I mean, let's be honest, if there weren't any costs, there'd be no need for this whole 2-day-long conference. They include discrimination to the self, which is that you're concerned that coworkers around you think that coworkers around you think. I lost my train of thought. You're concerned that coworkers around you may be prejudicial against you or discriminate against you. There's also concern about discrimination to friends and family. One of the interesting phenomena is that many family members experience what's called courtesy stigma, that they experience being stigmatized because they're associated with people with mental illness. A lot of times family members don't want the person to come out, because in coming out, that makes it a much bigger risk for them knowing that I'm a parent of a person with mental illness. There's also seems to be some effect for empathy. If you can manipulate empathy in a situation, then the impact in terms of stigma changes greatly. So, for example, we're in the midst of a study right now where we randomize people to two conditions, the same story, the same consumer. The situations is the one on the left is I want you to be empathic. I want you to walk in their shoes. And the one on the right is I want you to be cognitive. I want you to look at this in terms of aloofly, like a good scientist. And when they've done research on other groups, this tends to, the effect comes out, people are more successful in the empathy condition. So, to sum up, what we seem to know about anti-stigma interventions, and this is really where I am in my own research now, is how to move from doing well-controlled sort of research in the lab versus more broad spectrum kind of research. In our own voice as an anti-stigma group that NAMI's put together, we're keying up for a study of In Our Own Voice, which right now has about 100 different groups around the country. Contact seems to work especially well, especially if you're using empathy as an indicator, or if you're aware of how much the stigma conflicts with the stereotype. Education, the good news about education is it's very exportable. The problem with education is we seem to be somewhat of an education-oriented society. Namely, we're going to educate away stigma or any other kind of social problem we have. I'm not sure the jury is totally in on this, but I'm somewhat concerned about education as being a big avenue for research. Protests. Protest does not seem to work well for attitude change. Seems to have a significant outcome for behavioral consequences. So if you wanted to use protest as some sort of strategy to get a business group to stop acting that way, this may be the effective way to go. Let me end with a quote from the same man I started with. Success is to be measured not so much by the position one has reached in life as by the obstacles he has overcome while trying to succeed. I'm confident that we can succeed at this together, and good luck in the next 2 days. Thank you. Hello.
I'm interested in actually the stigma of psychiatric medications. I don't know if you can sort of comment on that at all. I feel, I'm a child psychiatrist, I feel that it seems like, and I've started to study this a bit, that that actually is, it seems to be a barrier to help seeking and to maintenance of treatment.
Okay. The question is, what's the stigma related to medication, especially with children? I think the problem with psychiatrists, medications, and offices is, and I don't think this problem is easily overcome, is that whenever we go to those associations, we're associated with the stigma, and that's where the labels come from. And so one of the big stigmas nowadays is having a label. And one of the great ways, this is why mental health offices are wisely so protective of who's there, who's not, because they're trying not to perpetuate the stigma. Most of our work so far has been on adults. What do we seem to know about kids? Well, the one thing in talking to groups is we've always been hesitant to do contact with kids because the best contact with kids is a kid, not an adult. And I think maybe we're being overprotective, but no group's been willing to do that with grade school kids.
What if a student's academics could greatly be helped by registering in the disabilities office of their university, but they are afraid of having it on their record because they don't want it to negatively impact their future careers? What would you recommend?
Yeah, I think at some point people need to decide for themselves whether they're going to wrestle with the label. I think one of the things this conference is doing is having that label is okay. I think if he or she is afraid of disabilities other than the usual confidential stuff they do, there's no way they can deal with it other than coming out. Also when I hear people say, what should they do because they're in this disability group and they'll go on your permanent record, something that also might be self-stigma might be the idea that you're bad because you're mentally ill. Yeah, contact me, and I can pass it on to Bob. My email address is p-corrigan 2, the number 2, at northwestern.edu.
And there's an elaboration question. You made reference to self-stigma. This is something that apparently this individual wants more details, and would you please redefine the components and elaborate with some examples?
Okay. Well, let me give you the short response. We tend to distinguish between public stigma, which is what we, the public, do to people with mental illness, versus self-stigma, which is what people with mental illness do to themselves. What they tend to do is they tend to buy into the stereotypes. Yep, all people with mental illness are incompetent, and they're to blame for their illness. They tend to turn it on against themselves, and I'm mentally ill, and therefore I'm incompetent and have mental illness. It leads to self-discrimination. Why try? You know, I'm a mentally ill guy. There's no way I can be successful. I'm not going to try University of Michigan.
How do you feel that health professionals might actually be contributing to stigma in this country?
Well, it's interesting. One response to that is when they do studies on professionals, psychiatrists tend to be among the most stigmatizing, which is interesting because if we're saying that contact has such a big effect, then why aren't they having a positive image on people with mental illness? Probably the big thought about that is that psychiatrists' work is largely driven by acute care. And so you're seeing people while they're seriously mentally ill. I think one of the things to help with stigma is consumer groups. So you want to send, does consumer play here? You know what that is? Consumer groups is one word for people, the person with mental illness. And so if you want to, I think if you have people who have stigma, you want to hook them up with self-help or other kind of groups because those are people of like mind, help them overcome it.